Hello, this is Emergency Care and Transportation of the Sick and Injured, Chapter 28, Head and Spine Injuries. In this chapter, we will be covering recognition of and care, treatment, and packaging of the patient who's involved in a potential head and spine injury and how to best care for them. Trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for acutely injured patients. We're going to again specifically focus on head, facial, neck, and spine trauma. We'll talk about the recognition of them and management of life threats and spinal trauma. We will be discussing the pathophysiology, assessment, and management of penetrating neck trauma and laryngotracheal injuries and spine trauma, facial fractures, skull fractures, foreign bodies in the eyes, and dental trauma. We'll also be discussing nervous system trauma, the pathophysiology, assessment, and management of traumatic brain injury and spinal cord injury. The nervous system is a complex network of nerve cells that enables all parts of the body to function. The nervous system includes the brain, spinal cord, and several billion nerve fibers that carry information to and from all parts of the body. Because the nervous system is so vital, it is well protected. The brain is protected by the skull, and the spinal cord is protected by the bony spinal canal. Despite this protection, serious injuries can damage the nervous system. Let's talk about the anatomy and physiology of these body systems. The nervous system is divided into two anatomic parts, the central nervous system and the peripheral nervous system. This figure shows the two components of the nervous system, the central nervous system and the peripheral nervous system. Make sure that you study this chart carefully and understand the difference between the central and peripheral nervous systems. Let's talk about the central nervous system first. It's also referred to as the CNS. This includes the brain and spinal cord. The brain controls the body and is, of course, the center of consciousness. The brain is divided into three major areas: the cerebrum, the cerebellum, and the brainstem. This figure shows the parts of the brain. So it not only shows the brainstem, which you see extending out of the bottom of the brain at the base, but it also shows the foramen magnum, which is the large opening at the base of the skull, and it also denotes the occipital lobe, parietal lobe, cerebral, frontal lobe, and the temporal lobe. So make sure that you commit these sections of the central nervous system and the brain to memory. The cerebrum controls a wide variety of activities, including most voluntary motor function and conscious thought. It contains about 75% of the brain's total volume. It's divided into two hemispheres with 4 lobes. The cerebellum coordinates balance and body movement. The brainstem controls most functions necessary for life, including the cardiac and respiratory systems and nerve function transmissions. It's best protected part of the CNS. So of all the parts of the CNS, the brainstem is the most protected. The spinal cord is mostly made up of fibers that extend from the brain's nerve cells. These carry messages between the brain and the body via the gray and white matter of the spinal cord. The gray matter is composed of neural cell bodies and synapses. The white matter consists of fiber pathways. Let's discuss the protective coverings. The cells of the brain and spinal cord are soft and easily injured. The entire CNS is contained within a protective framework. The thick bony structure of the skull and spinal canal withstand injury very well. It's also covered by layers of muscle and skin. The CNS is further protected by the meninges, which are three distinct layers of tissue that suspend the brain and the spinal cord within the skull and the spinal canal. The CNS is further protected by the meninges, three distinct layers of tissue that suspend the brain and the spinal cord within the skull and the spinal canal. The outer layer, the dura mater, is a tough, fibrous layer that forms a sac to contain the CNS. The inner two layers, called the arachnoid mater and the pia mater, contain the blood vessels that nourish the brain and spinal cord. This figure shows the layers of the protective coverings surrounding the brain. So you see it from the outer skin and fascia all the way down through the pia mater. So make sure that you commit this slide also to memory and understand the structure of the protective layers. Cerebrospinal fluid, also referred to as CSF, is produced in a chamber inside the brain called the third ventricle. There is approximately 125 to 150 milliliters of CSF in the brain at any time. CSF primarily acts as a shock absorber. When an injury does penetrate all of the protective layers, clear watery CSF may leak from the nose, the ears, or an open skull fracture. Now let's talk about the peripheral nervous system. There are 31 pairs of spinal nerves. These conduct impulses from the skin and other organs to the spinal cord. They also conduct motor impulses from the spinal cord to the muscles. The spinal nerves serving the extremities are arranged in very complex networks. This figure shows the major nerves of the peripheral nervous system. So you see it from the cerebrum in the brain all the way down through the very bottom of the spinal cord itself. There are 12 pairs of cranial nerves. These transmit information directly to or from the brain. These perform special functions in the head and face, including sight, smell, taste, hearing, and facial expression. There are two major types of peripheral nerves. There are sensory nerves that carry only one type of information from the body to the brain via the spinal cord. And there are motor nerves, one for each muscle. These carry information from the CNS to the muscles themselves. The connecting nerves are found only in the brain and the spinal cord. These connect the sensory and motor nerves with short fibers and allow the exchange of simple messages. Now let's discuss how the nervous system actually works. The nervous system controls virtually all of the body's activities, including reflex activities, voluntary activities, and involuntary activities. The connecting nerves in the spinal cord form a reflex arc. If a sensory nerve in this arc detects an irritating stimulus, it bypasses the brain and sends the message directly to a motor nerve, causing a response. This figure shows the reflex arc. So for example, you see a source of heat. It will bypass and go directly to the brain and cause a reflex, which forces you to withdraw your hand from the heat, as is illustrated in this particular slide. Voluntary activities are activities that we consciously perform in which sensory input determines the specific muscular activity. Involuntary activities are the actions that are not under conscious control, such as breathing. The somatic or voluntary nervous system handles voluntary activities. The brain interprets the sensory information that it receives from the peripheral and cranial nerves and responds by sending signals to the voluntary muscles. The autonomic or involuntary nervous system handles the body functions that occur without conscious effort. These control the functions of many of the body's vital organs. And it's divided into two sections, the sympathetic and parasympathetic nervous systems. When confronted with a threatening situation, the sympathetic nervous system reacts to the stress with a fight or flight response. This response causes the pupils to dilate, smooth muscle in the lungs to dilate, heart rate to increase, and blood pressure to rise. During this time of stress, a hormone called epinephrine or adrenaline is released. The parasympathetic nervous system has the opposite effect on the body, causing blood vessels to dilate, slowing the heart rate, and relaxing the muscle sphincters. As the body attempts to maintain homeostasis, these two divisions of the autonomic nervous system tend to balance each other so that basic body functions remain stable and effective. Now let's talk about the skeletal system as it relates to the nervous system. First and foremost, you have the skull. And the skull is composed of two groups of bones. The cranium, which is a thick shell above the eyes and ears that protects the brain, and the facial bones. The cranium is occupied by 80% brain tissue, 10% blood supply, and 10% CSF. The brain connects to the spinal cord through a large opening at the base of the skull called the foramen magnum. There are four major bones that make up the cranium. You have the occiput, which is the most posterior portion. In other words, it's the back of the skull. The temples or temporal regions, which are the lateral portions on either side of the cranium, and the parietal regions, which are between the temporal regions and the occiput. The frontal region is the forehead. The face itself is composed of 14 bones. You have the maxillae, which is the upper non-movable jawbone, and then the zygomas, which are the cheekbones, and the mandible, which is the lower movable portion of the jaw. The orbit or eye socket is made up of two facial bones, the maxilla and the zygoma. It also includes the frontal bone of the cranium. The nose mostly consists of flexible cartilage. Now let's talk about the spinal column. The spinal column is the body's central supporting structure. There are 33 vertebrae that are divided into 5 sections. The first is cervical, second is thoracic, third is lumbar, the fourth is sacral, and the 5 is the coccygeal. This figure shows the 5 sections of the spinal column, and you see they're in different colors. So you have the 7 bones of the cervical, they're in the pink, the thoracic is in the blue, lumbar is in the green, the sacrum is in the purple, and the coccyx is in the brown, right at the very bottom. Injury to the vertebra can result in paralysis. The front part of each vertebra consists of a round solid block of bone called the vertebral body, and the back part forms a bony arch. This series of arches form a tunnel called the spinal canal, which encases and protects the spinal cord. The vertebrae are connected by ligaments and separated by cushions called intravertebral discs. The spinal column is almost entirely surrounded by muscles. Now we're going to discuss head injuries. A head injury is a traumatic insult to the head that may result in injury to soft tissue, bony structures, or the brain itself. Approximately 4 million people experience head injuries of varying severity in the United States every year. 52,000 deaths occur annually as a result of severe head injury. Head injuries account for more than half of all traumatic deaths. Fatal injuries invariably involve the brain. Be alert to the fact that patients may have sustained additional trauma such as cervical spine injuries, pelvic injuries, and chest injuries. There are 2 general types of head injuries: closed head injuries, and open head injuries. Closed head injuries are those in which the brain has been injured, but there's no opening into the brain. An open head injury is one in which an opening from the brain to the outside world exists. Obvious skull deformity with a break in the skin is a sign of an open head injury, which is often caused by some type of penetrating trauma. There may be bleeding and exposed brain tissue. Motor vehicle crashes are the most common MOI. More than 2/3 of people involved in motor vehicle crashes experience a head injury. Head injuries also occur commonly in victims of assault, when elderly people fall, during sports-related incidents, in a variety of incidents involving children, and any head injury is potentially serious if not properly treated. The table on this slide shows the general signs and symptoms of a head injury, and as you can see, it's quite an extensive list. Make sure that you are extremely familiar with this list so that you know what to look for in specific MOIs or suspected MOIs, and you know what types of head injuries may be associated with those MOIs. Now let's talk about scalp lacerations. These can be minor or serious, and even small lacerations can quickly lead to significant blood loss. Occasionally, this blood loss may be severe enough to cause hypovolemic shock, particularly in children. Because scalp lacerations are usually the result of direct blows to the head, they are often an indicator of deeper, more serious injuries. Think back to that chart that we just looked at. So this is one instance where you might see kind of a severe scalp laceration, and it behooves you to investigate further and see what other types of head injuries may be lurking because of a result of that scalp laceration, for example. Now let's talk about skull fracture. Significant force applied to the head may cause a skull fracture. A skull fracture may be open or closed depending on whether there is an overlying laceration of the scalp. Injuries from bullets or other penetrating weapons frequently result in fracture of the skull. Signs of skull fracture include the patient's head appearing deformed, visible cracks in the skull, ecchymosis, which is bruising that develops under the eyes, which is called raccoon eyes, or ecchymosis that develops behind one ear over the mastoid process, which is Battle's sign. These figures show ecchymosis under the eyes in figure A, which is on the left, and behind one ear on B, which is the image on the right, and that's a result of a skull fracture. Linear skull fractures are what we're going to discuss now, and these are non-displaced skull fractures and account for approximately 80% of all fractures to the skull. Radiographs are required to diagnose a linear skull fracture because there are often no physical signs such as deformity. If the brain is uninjured and there are no scalp lacerations, then linear fractures are not life-threatening. Now we'll discuss depressed skull fractures. These result from high-energy direct trauma to the head with a blunt object. The frontal and parietal bones of the skull are most susceptible. Bony fragments may be driven into the brain, resulting in injury and insult to the brain. Patients often present with neurologic signs such as loss of consciousness. Now we'll discuss basilar skull fractures. These are associated with high energy trauma, but usually occur following diffuse impact to the head from falls or motor vehicle crashes, for example. These injuries generally result from the extension of a linear fracture to the base of the skull and can be difficult to diagnose without radiography. Signs of a basilar skull fracture include CSF drainage from the ears, raccoon eyes, and battle sign. Now let's take a look at open skull fractures. Open fractures of the cranial vault result when severe forces are applied to the head and are often associated with trauma to multiple body systems. Brain tissue may be exposed to the environment, which significantly increases the risk of bacterial infection, and these usually have a high mortality rate. Now, traumatic brain injuries is what we're going to discuss now. And the National Head Injury Foundation defines a TBI as, quote, a traumatic insult to the brain capable of producing physical, intellectual, emotional, social, and vocational changes, unquote. These are the most serious of all head injuries, and they're classified in two broad categories: primary, which is direct injury, and secondary, which is indirect injury. The primary brain injury results instantaneously from impact to the head. Secondary brain injury increases the severity of the primary injury and may be caused by hypoxia, hypotension, cerebral edema, intracranial hemorrhage, increased intracranial pressure, cerebral ischemia, and infection. The brain can be injured directly by a penetrating object such as a bullet, knife, or other sharp object, or indirectly as a result of external forces exerted on the skull itself. A coup contra coup injury can result from striking a windshield in a car crash. The passenger's head hits the windshield, and the brain continues to move forward until it comes to an abrupt stop by striking the inside of the skull. So in other words, the brain goes back and forth and strikes the inside of the skull. The head falls back against the headrest and or seat, and then the brain slams into the rear of the skull. So coup contra coup means that the impact causes the brain to impact the inside of the front of the skull, and then as the head snaps back, the brain slams into the back inside of the skull. Cerebral edema or swelling of the brain may not develop until several hours following the initial injury. Low blood oxygen levels aggravate cerebral edema and can be minimized by maintaining high oxygen saturations. It is not uncommon for the patient with a head injury to have a convulsion or a seizure. Now we'll discuss intracranial pressure. Accumulations of blood within the skull or swelling of the brain can rapidly lead to an increase in intracranial pressure, also abbreviated as ICP. Increased ICP squeezes the brain against the bony prominences within the cranium. Signs of increased intracranial pressure are Cheyne-Stokes respirations, ataxic or Biot respirations, decreased pulse rate, headache, nausea, vomiting, decreased alertness, bradycardia, sluggish or non-reactive pupils, decerebrate posturing, increased or widened blood pressure, Cushing reflex, which is a triad of increased systolic blood pressure, decreased pulse rate, and irregular respiration, and these signify increased ICP. Intracranial hemorrhage is what we're going to discuss now, and that is bleeding inside the skull, which also increases the ICP, which is intracranial pressure. Bleeding can occur between the skull and the dura mater, between the dura mater but outside the brain, or within the tissue of the brain itself. Here's an example of an epidural hematoma. This is an accumulation of blood between the skull and the dura mater. It nearly always is the result of a blow to the head that produces a linear fracture of the thin temporal bone. Arterial bleeding into the epidural space will result in rapidly progressing symptoms. Often, the patient loses consciousness immediately following the injury. This is often followed by a brief period of consciousness, which is called a lucid interval, after which the patient lapses back into unconsciousness. Death will follow very rapidly without surgery to evacuate the hematoma. Now let's discuss subdural hematoma. This is an accumulation of blood beneath the dura mater but outside the brain. It usually occurs after falls or injuries involving strong deceleration forces. It's more common than an epidural hematoma and may or may not be associated with a skull fracture. A subdural hematoma is associated with venous bleeding, so the signs typically develop more gradually than with an epidural hematoma. The patient often experiences a fluctuating level of consciousness or slurred speech. Any patient with a suspected subdural hematoma needs to be evaluated by a physician right away. Now we'll talk about intracerebral hematoma. This involves bleeding within the brain tissue itself, and it can occur following a penetrating injury to the head or because of rapid deceleration forces. Many small, deep intracerebral hemorrhages are associated with other brain injuries. Intracerebral hematomas have a high mortality rate even if the hematoma is surgically evacuated. Now we'll talk about a subarachnoid hemorrhage. Bleeding that occurs into the subarachnoid space where the CSF circulates is what this is, and it results in bloody CSF and signs of meningeal irritation. The common causes include trauma or rupture of an aneurysm. The patient reports a sudden severe headache. A sudden severe subarachnoid hematoma usually results in death, and survivors often have permanent neurological impairment. Now we'll discuss concussion. This is a blow to the head or face, and it may cause a concussion of the brain. Concussions are also known as mild TBIs. In general, it is a closed injury with a temporary loss or alteration of part or all of the brain's abilities to function without demonstrable physical damage to the brain. Approximately 90% of patients who sustain a concussion do not experience a loss of consciousness. A patient with a concussion may be confused or have amnesia. Occasionally, the patient may have retrograde amnesia, which means that he or she can remember everything but the events leading up to the injury. The inability to remember events after the injury is called anterograde or post-traumatic amnesia. Usually a concussion only lasts a short time, but you should ask about symptoms of concussion in any patient who has sustained an injury to the head, including dizziness, weakness, visual changes, nausea, vomiting, ringing in the ears, slurred speech, or an inability to focus. With concussion, you can also have lack of coordination, delay of motor functions, and inappropriate emotional responses, temporary headache, disorientation. You should assume that a patient with signs or symptoms of concussion has a more serious injury until proven otherwise. All patients with signs or symptoms of a concussion should be evaluated by a physician. Now we'll talk about contusion. Like any other soft tissue in the body, the brain can sustain a contusion or a bruise when the skull is struck. A contusion is far more serious than a concussion. It involves physical injury to the brain tissue, and it may produce a long-lasting or even permanent change or damage. A patient who has sustained a brain contusion may exhibit any or all of the signs of brain injury. Now, some other brain injuries that we need to discuss are the following: Brain injuries can rise from medical conditions such as blood clots or hemorrhages. Problems with the blood vessels, high blood pressure, or other problems may cause spontaneous bleeding into the brain, affecting the patient's level of consciousness. This is known as altered mental status. The signs and symptoms of non-traumatic injuries are often the same as those of TBIs, and even if there is no obvious history of MOI or any external evidence of trauma. Now we'll discuss spine injuries. The cervical, thoracic, and lumbar portions of the spine can be injured in a variety of ways. Compression injuries can result from a fall, regardless of whether the patient landed on his or her feet or experienced a direct blow to the crown of the skull, coccyx, or the top of the head. Forces that compress the patient's vertebral body can cause herniation of discs, the subsequent compression on the spinal cord and nerve roots, and fragmentation into the spinal canal itself. Motor vehicle crashes or other types of trauma can overextend or hyperflex the cervical spine and damage the ligaments and joints. Rotation flexion injuries of the spine result from rapid acceleration forces. These are more likely to happen at C1 and C2. Injuries to this area of the spine are considered unstable due to the location and lack of bony and soft tissue support. Any one of these unnatural motions, as well as excessive lateral bending, can result in fractures or neurologic deficit. When the spine is pulled along its length, which is hyperextension, it can cause fractures in the spine as well as ligament and muscle injuries. When bones of the spine are altered from traumatic forces, they can fracture or move out of place. When injuries pinch, pull, or penetrate the spinal cord, permanent damage may occur. Common findings include pain and tenderness on palpation. You may feel or observe a deformity of the spine, which is called a step-off, where the spinous process may be palpable. If you suspect these types of injuries, take extra precautions when stabilizing the spine. Now we'll discuss patient assessment. Always suspect a possible head or spinal injury anytime you encounter one of the following MOIs. Motor vehicle collisions, including motorcycles, snowmobiles, and all-terrain vehicles. Pedestrian versus motor vehicle collisions. Falls greater than 20 feet in an adult, greater than 10 feet in pediatric. Blunt trauma or penetrating trauma to the head, neck, back, or torso. You also want to suspect a possible head or spinal injury if you have rapid deceleration injuries, hangings, axial loading injuries, where load is applied along the vertical or longitudinal axis of the spine, such as falling from a height and landing on the feet in an upright position, and diving accidents. Now we'll talk about scene size up, which we do all the time. And of course, the big priority is scene safety. Evaluate every scene for hazards to your health and the health of your team or bystanders. Be prepared with appropriate standard precautions before you approach the patient in a motor vehicle crash. Gloves, a mask, and eye protection should be the minimum standard precautions that you use. Call for ALS as soon as possible when a serious MOI or complicated presentation is evident. Law enforcement may be needed to control traffic or crowds. Also, in terms of scene size up, you need to consider the mechanism of injury and the nature of illness. Look for indicators of the MOI. Consider how the MOI produced the injuries expected, and continue to consider the MOI while assessing a patient. In terms of primary assessment, you want to focus on identifying and managing life-threatening concerns. Threats to circulation, airway, or breathing are considered life-threatening and must be treated immediately. Life-threatening external hemorrhage must be addressed before airway and breathing concerns. Most head injuries are considered mild and result in no or limited permanent disability. A number of patients with head or spine injuries will not require much intervention other than a thorough assessment and continued observation during transport. In patients who have problems with ABCs or have other conditions for which you should decide a rapid transport to the closest appropriate hospital is needed, rapid immobilization of the spine and quick loading into the ambulance may be indicated. Reduction of on-scene time and recognition of critical patient increases the patient's chances for survival or a reduction in the amount of irreversible damage. Now let's talk about spinal immobilization considerations. When assessing a patient, be aware that any unnecessary movement of the patient can cause additional injury. Assess the patient in the position found. Determine whether or not a cervical collar needs to be applied. Begin by assessing the scene to determine the risk of injury. Then form a general impression of your patient based on his or her level of consciousness and the chief complaint. If the patient is absolutely clear in his or her thinking and does not have any neurologic deficits, spinal pain or tenderness, evidence of intoxication, or other illnesses or injuries that may mask a spinal injury, you may consider not placing a patient in a spinal restriction at all. The backboard is rigid and often places the patient in an anatomically incorrect position for a long period of time. Circulation to areas of skin may become compromised, leading to complaints of pain, ischemia to the skin, and if left long enough, necrosis. Some patients, especially bariatric patients, could experience respiratory compromise while lying flat. Consider placing padding under the patient to help minimize the risk of injury and to try to minimize the amount of time a patient is on a long backboard. Apply a cervical collar as soon as you have assessed the airway and breathing and provided necessary treatments. This helps maintain spinal immobilization as you treat the airway and breathing. The best time to apply the cervical collar depends on the patient's injuries and the seriousness of his or her condition. Once the cervical collar is on, do not remove it unless it causes a problem with maintaining the airway. Assessing for signs and symptoms of a head or a spine injury. Begin by asking the responsive patient the following questions. What happened? Where does it hurt? Does your head or back hurt? Does your neck or back hurt? If the patient is found unresponsive, emergency responders, family members, or bystanders may have helpful information. Unresponsive trauma patients should be assumed to have a spinal injury. Patients with a decreased level of responsiveness on the AFPU scale should be considered to have a spinal injury based on their chief complaint. Airway, breathing, and circulation considerations are always the priority. When a spinal injury is suspected, how you open and assess the airway is very important. Begin by manually holding the patient's head still while you assess the airway. Use a jaw thrust maneuver to open the airway. If the jaw thrust maneuver is ineffective, it is acceptable to use the head tilt chin lift maneuver as a last resort, but make sure you tilt it just enough to allow airflow. As an oropharyngeal or nasopharyngeal airway may assist in maintaining the airway. Vomiting may occur in the patient with a head injury, so be aware of that. The patient may need to be log rolled to the side and have the mouth swept of secretions. Suctioning should be performed immediately to remove smaller particles or smaller amounts of secretions. Irregular breathing, such as Cheyne-Stokes respirations, may result from increased pressure on the brain because of bleeding or swelling in the cranium. Pre-hospital administration of high-flow oxygen is indicated for patients with head and spinal injuries. Pulse oximeter values should not fall below 90% and ideally should be 95% or higher. Hyperventilation or ventilating too fast or with too much force should be reserved for specific conditions and performed under specific guidelines because it can increase the severity of head injuries, and it should be avoided except in cases where signs of herniation have been identified. Always assess airway and breathing prior to moving on to assessment of circulation. A pulse that is too slow in the setting of a head injury can indicate a serious condition in your patient. If the pulse is present and adequate, you can continue to evaluate your patient further. A single episode of hypoperfusion in a patient with a head injury can lead to significant brain damage and even death. Assess for signs and symptoms of shock and treat appropriately. Make sure to control bleeding. When bandaging the head, be careful not to move the neck if spinal injuries are suspected. Do not apply pressure if a skull fracture is suspected. Manner of transport. Several transport considerations should be kept in mind for patients with head trauma. Patients with impaired airways, open head wounds, or abnormal vital signs, or patients who do not respond to painful stimuli may need to be rapidly extricated from a motor vehicle and transported. Providing the patient with a patent airway and high flow oxygen is paramount. If there is a probability of vomiting and seizures, so suction should be readily available. A head trauma patient may deteriorate rapidly and require aeromedical support or transport. In supine patients, the head should be elevated 30 degrees if possible to help reduce ICP or intracranial pressure. Remember to maintain immobilization of the spine. The use of lights and sirens may increase the patient's level of distress, so bear that in mind. Patients who are conscious and aware of the inability to move their limbs need to be offered emotional support. Now we'll discuss history taking. Investigate the chief complaint. Obtain a medical history and be alert for injury-specific signs and symptoms as well as any permanent negatives. Using OPQRST may provide some background on isolated extremity injuries. Any information you receive will be very valuable if the patient loses consciousness. If the patient is not responsive, attempt to obtain history from other sources such as friends, family members, medical identification jewelry, and cards in wallets. Gather as much sample history as you can while preparing for transport. Now let's discuss secondary assessment. Remember that the ability to walk, move the extremities, or feel sensation, as well as the absence of pain, does not necessarily rule out a spinal cord injury. Instruct the patient to keep still and not move the head or neck. With physical examinations, it may be a systematic head-to-toe, full-body scan, or a systematic assessment that focuses on certain areas or regions of the body. Patients with moderate or severe head injuries should receive life-saving medical or surgical intervention at the closest appropriate trauma hospital. If time allows, perform a secondary assessment while en route. Obtaining a complete set of baseline vital signs is essential. Significant head injuries may cause the pulse to slow and the blood pressure to rise. With neurogenic shock, the blood pressure may drop and the heart rate may increase to compensate. Respirations will become erratic with complications from both head and spine injuries. Hypotension may be present with cervical or high thoracic spine injuries. The heart rate may become slow or fail to increase in response to hypotension. In addition to hands-on assessment, you should use monitoring devices to quantify your patient's oxygenation and circulatory status. Pulse oximetry and E2CO2 monitoring should be utilized if available. Maintain an EtCO2 between 35 and 40 millimeters of mercury, and you may also use a non-invasive method to monitor blood pressure. With physical exam considerations, examine the entire body using DCAP BTLS and examine the head, chest, abdomen, extremities, and back. Check perfusion, motor function, and sensation in all extremities prior to moving the patient. A decreased or altered level of consciousness is the most reliable sign of a head injury. Determine whether there is decreased movement and/or numbness and tingling in the extremities. Look for blood or CSF leaking from the ears, nose, or mouth, and for bruising around the eyes and behind the ears. Assess pupil size and reaction to light, and continue to monitor the pupils because any change in their reactions over time may indicate progressive brain injury. Do not probe open scalp lacerations with your gloved finger because this may push bone fragments into the brain. Do not remove an impaled object from an open head injury. With the neurologic examination, you need to perform a baseline assessment using the Glasgow Coma Scale, or GCS. Always use simple, easily understood terms when reporting the level of consciousness. If your jurisdiction uses the Revised Trauma Score, or RTS, then the findings from the GCS will be used in determining the RTS value. Record levels of consciousness that fluctuate or deteriorate. As you proceed with your assessment, ask, is the patient's speech clear and appropriate? Does the patient answer in a manner that's logical? And is the patient able to make decisions? Is the patient aware of his or her current location? Is the patient alert to person, place, time, and why you are at the scene? And can the patient recall the events leading up to the incident, or is there a period of memory lapse? Can the patient recall major current events? Any person with a head injury that has resulted in a change of consciousness, progressive development of signs and symptoms of a concussion, or other causes of concern should be evaluated by a qualified healthcare provider. The table on this slide shows the categories of the Glasgow Coma Scale. This is absolutely something you must commit to memory, so please study it carefully. With spine examination, you need to check if there is a potential spine injury and examine the spine. Inspect for DCAP BTLS and check the extremities for circulation, motor, or sensory problems. If there is impairment, note the level. Pain or tenderness when you palpate the spinal area is a warning sign that a spinal injury may exist. Other signs and symptoms include an obvious deformity, numbness, weakness, or tingling in the extremities, and soft tissue injuries in the spine region. Injuries to the cervical area can limit the ability of the diaphragm to function fully and minimize the ability of the chest wall to fully expand. Additional signs include abdominal excursion, an inability to maintain body temperature, priapism, and a loss of bowel or bladder control. Now, with reassessment, you want to repeat the primary assessment, reassess vital signs and the chief complaint, and recheck patient interventions. These injuries can suddenly affect the respiratory, circulatory, and nervous systems, and the patient's condition should be reassessed at least every 5 minutes. In terms of interventions, multiple interventions may be necessary in patients with a head and spinal injuries. If something is not working, try something else. Compare baseline vital signs with repeated vital signs, and changes will often tell you if treatments have been effective. Watch carefully for changes in the pulse, blood pressure, and respirations. Document changes in the level of consciousness. Rapid deterioration of neurologic signs following a head injury is a sign of an expanding intracranial hematoma or rapidly progressing brain swelling. You will notice a deterioration in a conscious patient's awareness of time, place, and person, or their sense of self in that order. You must act quickly to evaluate and treat these patients. If CFS is present, cover the wound with sterile gauze to prevent further contamination, but do not bandage it tightly. Your protocol should include the administration of high-flow oxygen and the application of a cervical collar, if indicated, as part of spinal immobilization. Reassessment should take place as the patient is transported to an appropriate trauma facility. Now, with communication and documentation, it is essential to maintain good communication with other providers and give complete and detailed information to the destination facility. Hospitals may better prepare for seriously injured patients with more advanced warning and a description of the most serious problems found during your assessment. Your documentation should include the history you were able to obtain at the scene, your findings during your assessment, treatments you provided, how the patients responded to them. More seriously injured patients should have documented vital signs every 5 minutes, and more stable patients should have documented vital signs every 15 minutes. You may be requested to testify as a witness. With emergency care of head injuries, there are 3 general principles that are designed to protect and maintain the critical function of the CNS, or the central nervous system. Establish an adequate airway. If necessary, begin and maintain ventilation, and always provide high-flow supplemental oxygen. Number 2, control bleeding and provide adequate circulation to maintain cerebral perfusion. Begin CPR if necessary, and be sure to follow standard precautions. Number 3, assess the patient's baseline level of consciousness and continuously monitor it. With managing the airway, the most important step is establishing and maintaining an adequate airway. If the patient has an airway obstruction, perform the jaw thrust maneuver. Once the airway is open, maintain the head and cervical spine in a neutral inline position until you have placed a cervical collar and have secured the patient on a backboard. This figure shows how to stabilize and maintain the head and cervical spine in a neutral inline position and then apply a cervical collar. This is also a skill you'll practice. Remove any foreign bodies, secretions, or vomitus from the airway. Make sure a suctioning unit is available. Once you have cleared the airway, check ventilation. Give supplemental oxygen to any patient with suspected head injury, particularly anyone who's having trouble breathing. In regards to circulation, if the heart is not beating, provide airway maintenance, ventilation, and oxygen accomplishes nothing if you don't have an adequate airway. You must begin CPR if the patient is in cardiac arrest and they have a patent airway. Active blood loss aggravates hypoxia by reducing the available number of oxygen-carrying red blood cells. So bleeding inside the skull may cause the ICP to rise to life-threatening levels. You can almost always control bleeding from a scalp laceration by applying direct pressure over the wound. If you suspect a skull fracture, do not apply excessive pressure to the open wound. If the dressing becomes soaked, do not remove it. Just place another on top of it. Instead, place the second dressing over the first and loosely bandage. Just enough to secure it. In regards to shock, usually the result of hypovolemia caused by bleeding from other injuries produces shock, and this indicates that the situation is critical, so they must be transported immediately to a trauma center. Cushing triad is increased blood pressure or hypertension, a decreased heart rate, which is bradycardia, and irregular respiration, which is Cheyne-Stokes or Byatt respirations. If this process is allowed to continue, it is a fatal injury. Perform controlled hyperventilation of your patient via positive pressure ventilations at a rate of 20 breaths per minute. Follow local protocols and your medical direction in regard to hyperventilation in the presence of herniation. Emergency care of spinal injuries. Remember to follow standard precautions. Maintain the patient's airway while keeping the spine in the proper position, assess respirations, and give supplemental oxygen. Managing the airway. Perform the jaw thrust maneuver to open the airway. Do not use the head tilt chin lift maneuver because it extends the neck and may further damage the cervical spine. After you open the airway, consider inserting an oropharyngeal airway. Have a suctioning unit available and provide supplemental oxygen. This figure shows how to perform a proper jaw thrust maneuver. This is also a skill you'll practice. Immobilization of the cervical spine. Establishing and maintaining the airway is always your first priority. Immobilize the head and trunk so that bone fragments do not cause further damage. Even small movement can cause significant injury to the spinal cord. Follow the steps in skill drill 28-1. Never force the head into a neutral inline position, and do not move the head any further if the patient reports any of the following symptoms: muscle spasms in the neck, substantial increased pain, numbness, tingling, or weakness in the arms or legs, or a compromised airway or ventilations. In these situations, stabilize the patient in his or her current position. Now let's discuss cervical collars. They provide preliminary partial support, and they should be applied to every patient who has a possible spinal injury based on the MOI, history, or signs and symptoms. Cervical collars do not fully immobilize the cervical spine. Therefore, you must maintain manual support until the patient has been completely secured to a long or short backboard or some type of vacuum mattress. To be effective, a rigid cervical collar must be the correct size for the patient. The cervical collar should rest on the shoulder girdle and provide firm support under both sides of the mandible without obstructing the airway or ventilation. Follow the steps in skill drill 28-2 in your text. Once the patient's head and neck have been manually stabilized, assess the pulse, motor functions, and sensation in all extremities. Then assess the cervical spine area and neck. With preparation for transport, supine patients first need to be immobilized by securing the patient to a long backboard or a vacuum mattress. Another procedure to move a patient from the ground to a backboard is the 4-person log roll. You may also slide the patient onto a backboard or a vacuum mattress. To secure a patient to a backboard, follow the steps in skill drill 28-3. Now we'll discuss a vacuum mattress. This is an alternative to the long backboard, and that is effective because it molds to the specific contours of the patient's body, reducing pressure point tenderness and therefore providing better comfort. It also provides thermal insulation. It's excellent for the elderly or a patient with abnormal curvature of the spine. The drawback to this device is its thickness. It requires careful patient movement to maintain spinal stabilization. It cannot be used for patients who weigh more than 350 pounds. It can be used on a supine, sitting, or standing patient. The patient can be moved onto the vacuum mattress with a scoop stretcher or a log roll. Follow the steps in skill drill 28-4 to immobilize a patient with a vacuum mattress. Sitting patients. Some patients with a possible spinal injury will be in a sitting position, such as after a vehicle crash. Use a short backboard or other short spinal extrication device to restrict movement of the cervical and thoracic spine. Then secure the short backboard to the long backboard. The exceptions to this rule are situations in which you do not have time to first secure the patient to the short board, including the following situations. You or the patient are in danger. You need to gain immediate access to other patients. The patient's injuries justify urgent removal. And in all other cases, follow the steps in skill drill 28-5 to immobilize a sitting patient using a commercial immobilization device. For standing patients, you need to immobilize the patient to a long backboard before proceeding with assessment. This process requires 3 EMTs. Begin by establishing manual inline stabilization and applying a cervical collar. Instruct the patient to remain still. Position the board upright directly behind the patient, and the EMTs should be positioned with one on either side of the patient and the third directly behind the patient, maintaining inline stabilization. The 2 EMTs at the patient's sides grasp the handholds at shoulder level or slightly above by reaching under the patient's arms. Carefully lower the patient as a unit under the direction of the EMT at the head. The EMT at the head must ensure that the patient's head stays against the board and must carefully rotate his or her hands as the patient is being lowered to maintain inline stabilization. Spinal immobilization devices. During assessment, pain in the spine may be missed because of shock or because the patient's attention is directed to more painful injuries. Because any manipulation of the unstable cervical spine may cause permanent damage to the spinal cord, you must assume the presence of spinal injury in all patients who have sustained head injuries. Use manual inline stabilization or a cervical collar and a long backboard. Now let's talk about short backboards. We mentioned them briefly earlier. The most common short backboards are the vest-type device and the rigid shortboard. These devices are designed to immobilize and restrict movement of the head, neck, and torso. They're used to immobilize non-critical patients who are found in a sitting position and have possible spinal injuries. Long backboards are devices that provide full-body spinal immobilization and motion restriction to the head, neck, torso, pelvis, and extremities. Long backboards are used to immobilize patients who are found in any position, sometimes in conjunction with short backboards. Now we'll discuss helmet removal. As you plan your care of a patient wearing a helmet, ask yourself the following questions. Is the patient's airway clear? Is the patient breathing adequately? Can I maintain the airway and assist ventilations if the helmet remains in place? Can the face guard be easily removed to allow access to the airway without removing the helmet? How well does the helmet fit? Can the patient move within the helmet? Can the spine be immobilized in a neutral position with the helmet on? A helmet that fits well prevents the patient's head from moving and should be left on provided that there are no impending airway or breathing problems, or it does not interfere with assessment and treatment of airway or ventilation problems. It should also stay in place if you can properly immobilize the spine and if there's any chance that removing it will further injure the patient. Remove a helmet if it is a full face helmet, it makes assessing or managing an airway problem difficult, and removal of a face guard to improve airway access is not possible. It prevents you from properly immobilizing the spine. It allows excessive head movement, and the patient is in cardiac arrest. So any of those criteria would dictate helmet removal. Just be extremely careful. The preferred method of helmet removal is to remove a helmet that should always be at least a two-person job. And the technique for helmet removal depends on the actual type of helmet worn by the patient. You and your partner should not move at the same time. You should first consult with medical control about your decision to remove a helmet and follow the steps in Skill Drill 28-6. Now, an alternate method of helmet removal is the following. The advantage of this method is that it allows the helmet to be removed with the application of less force, thereby reducing the likelihood of motion occurring in the neck. The disadvantage is that it is slightly more time-consuming. Steps to the alternate method are: remove the chin strap, remove the face mask, cut or unscrew the plastic clips, pop the jaw pads out of place with a tongue depressor, place your fingers inside the helmet during removal of the helmet, and the person at the side of the patient controls the head by holding the jaw with one hand and the occiput with the other. Insert padding behind the occiput to prevent neck extension. The person at the side of the patient's chest is responsible for making sure that the head and neck do not move during removal of the helmet. Remember that small children may require additional padding to maintain inline neutral position. Okay, class, let's do a review on this very important subject matter. Question 1. The brain, a part of the central nervous system, or CNS, is divided into the A, cerebrum, cerebellum, and brainstem; B, cerebrum, brainstem, and spinal cord; C, cerebellum, cerebrum, and spinal cord; and D, spinal cord, cerebrum, and cerebral cortex. If you know basic anatomy and physiology, this one is a very easy answer. It is, of course, A. The brain and spinal cord comprise the central nervous system, or CNS. The brain is divided into three major regions: the cerebrum, which is the largest portion, the cerebellum, and the brainstem. Each region of the brain carries out specific functions. But if you look at the incorrect answers, you see the following. Let's review them. Question 1, the brain, a part of the central nervous system, is divided into the A, cerebrum, cerebellum, and brainstem. That's the correct answer. B says cerebrum, brainstem, and spinal cord, but we know the spinal cord is not part of the brain. C, the cerebellum, cerebrum, and spinal cord. Again, the spinal cord is not part of the brain, and that's also the case for D. So let's move on to question 2. As you are assessing a 24-year-old man with a large laceration to the top of his head, you should recall that A, the scalp, unlike other parts of the body, has relatively fewer blood vessels. B, blood loss from a scalp laceration may contribute to hypovolemic shock in adults. C, any avulsed portions of the scalp should be carefully cut away to facilitate bandaging. Pardon me, but gross. And D, Most scalp injuries are superficial and are rarely associated with more serious injuries. I think that you'll remember this one quite easily. The answer is, of course, B. Although the scalp is highly vascular and tends to bleed heavily when injured, scalp injuries are rarely the sole cause of hypovolemic shock in adults. However, they can contribute to hypovolemia caused by injuries elsewhere in the body. Scalp lacerations, whether deep or superficial, should prompt you to look for more serious underlying injuries, such as a skull fracture, where you might have bleeding into the brain. If the injury involves an avulsion, the avulsed flap of skin should be carefully replaced to its original position and not cut away. And pardon me for my explicative, but that's just awful to consider. Moving on to question 3. So let's look at the incorrect answer. As you are assessing a 24-year-old man with a large laceration to the top of his head, you should recall that A, the scalp, unlike other parts of the body, has relatively fewer blood vessels. That's incorrect because we know the scalp is highly vascular. B, blood loss from scalp laceration may contribute to hypovolemic shock in adults. This is correct because if you consider that someone has a severe scalp laceration, it is distinctly possible that they have either complicating medical condition where a lower blood volume can cause serious problems, or they may have an injury to the skull where they're bleeding into the brain, which is also causing potential hypovolemic shock or problems. C, any avulsed portions of the scalp should be carefully cut away to facilitate bandaging. I'm sorry, but that just is a horrible image to me. The avulsed flap should be carefully replaced to its original position. And D, most scalp injuries are superficial and are rarely associated with more serious injuries. Well, that's not necessarily true. Deep or superficial scalp lacerations should always prompt EMS providers to assess for more serious underlying injuries. A patient who experiences an immediate loss of consciousness followed by a lucid interval has an epidural hematoma, a subdural hematoma, a concussion, or a contusion. It is A. An epidural hematoma are caused by an injury to an artery, usually the middle meningeal artery that lies in between the skull and the brain. Patients with an epidural hematoma typically experience an immediate loss of consciousness followed by a brief period of consciousness, which is called a lucid interval, as intracranial pressure increases. Subdural hematomas are the result of injury to a vein, therefore they tend to bleed slowly and usually cause a progressive decline in level of consciousness. Concussions and contusions may cause a loss of consciousness, but they are typically brief. Since we reviewed all of the incorrect answers along with the correct answers, I'm not going to go over them again here in question 3. But do make sure that you study and know the differences between epidural hematoma, subdural hematoma, concussion, and contusion. A 44-year-old man was struck in the back of the head and was reportedly unconscious for approximately 30 seconds. He complains of a severe headache and quote-unquote seeing stars, and states that he regained his memory shortly before your arrival. His presentation is most consistent with a contusion, a concussion, a subdural hematoma, or an intracerebral hemorrhage. Let's check the correct answer on this one. It is B. A concussion occurs when the brain is jarred around inside the skull. It may result in a brief loss of consciousness and occasionally amnesia. Seeing stars is a common finding following trauma to the back of the head, the occiput, as this is the region that is primarily responsible for vision. A concussion, the least severe of all closed head injuries, typically does not result in physical damage to the brain. Compared to a concussion, a contusion, subdural hematoma, and intracerebral hemorrhage are usually associated with a more prolonged loss of consciousness. And just like in question 3, we've reviewed the correct answer along with all of the incorrect answers. So let me just emphasize again here, know the definition of contusion and know the differences as well. Know the differences and definition of contusion, concussion, subdural hematoma, and intracerebral hemorrhage. Question 5. A young male was involved in a motor vehicle accident and experienced a closed head injury. He has no memory of the events leading up to the accident, but does remember that he was going to a birthday party. What is the correct term to use when documenting his memory loss? A. Concussion, B. Cerebral contusion, C. Retrograde amnesia, or D. Anterograde amnesia? Let's see if you get this one right. It is C. The term amnesia means loss of memory. It is common in patients who have experienced a cerebral concussion. Amnesia of events leading up to an injury is called retrograde amnesia. Anterograde amnesia, also called post-traumatic amnesia, is the inability to remember events that occurred or will occur after the injury. We covered in this question also the correct answer and the incorrect answers. So let's move on and let's make sure that you remember and know the differences between concussion, cerebral contusion, retrograde amnesia, and anterograde amnesia. Moving on to question 6. A distraction injury to the cervical spine would most likely occur following A. a diving accident, B. blunt neck trauma, C. hyperextension of the neck, or D. a hanging type mechanism. The answer is D. Excessive traction on the neck, such as what occurs during a hanging type mechanism, can cause a distraction injury of the cervical spine. Distraction injuries can cause separation of the vertebra and stretching or tearing of the spinal cord. Question 6. Let's review the incorrect answers. A distraction injury to the cervical spine would most likely occur following a diving accident. That's incorrect. A diving accident would possibly cause a compression injury. That's why at pools, especially in the shallow end, you see no diving, because people dive into the shallow end and they have a compression injury to the top of their head from hitting the bottom of the pool. B. Blunt neck trauma. That's incorrect because this can result in a fracture or a neurologic defect. C. Hyperextension of the neck. That's incorrect because this can result in a fracture or a neurologic defect. And D is, of course, the correct answer. A distraction injury to the cervical spine would most likely occur following a hanging type mechanism. Question 7. During immobilization of a patient with a possible spinal injury, manual stabilization of the head must be maintained until A. an appropriate size extrication collar has been placed, B. the patient is fully immobilized on a long backboard, C. a range of motion test of the neck has been completed, or D. a pulse, motor, and sensory functions are found to be intact. This one should be fairly straightforward, so I know you'll get this one right. The answer is B. Manual stabilization of the patient's head must be maintained until he or she is fully secured to the long backboard. Because if you remember, the cervical collar alone does not provide total stabilization. That's not achieved until they're fully attached to the backboard. So let me finish reading this because that's pretty much what I just said. And let me start from the very beginning of the answer again. Manual stabilization of the patient's head must be maintained until he or she is fully secured to a long backboard. This includes the application of an extrication collar, straps, and lateral immobilization, which are head blocks. Pulse, motor, and sensory functions must be checked before and after the immobilization process. Do not assess range of motion in a patient with a possible spinal injury. This involves moving the patient's neck and may cause further injury. So let's look at the incorrect answers on number 7. Just to review the question, during immobilization of a patient with a possible spinal injury, manual stabilization of the head must be maintained until A, an appropriate size extrication collar has been placed. This is only one part of the total immobilization process, so this is an incorrect answer. B, the patient is fully immobilized on a long backboard. That's the correct answer. C, a range of motion test of the neck has been completed. That's completely wrong. Do not assess range of motion in a patient with a possible spinal injury, or they may never have any motion again. And D, pulse, motor, and sensory functions are found to be intact. This is done before and after complete immobilization. That's to make sure that you don't have them placed with straps that are too tight or in an incorrect position, etc. Question 8. Your patient is a 21-year-old male who has massive face and head trauma after being assaulted. He is lying supine, is semi-conscious, and has blood in his mouth. You should A, insert a nasal airway, assess his respirations, and give 100% oxygen. B, suction his airway and apply high-flow oxygen via a non-rebreathing mask. C, manually stabilize his head, log roll him onto his side, and suction his mouth. Or D, apply a cervical collar, suction his airway, and begin assisting his ventilations. So read these carefully, and I'm sure you're going to be able to select the correct one. So here we go. It is C. Blood or other secretions in the mouth place the airway in immediate jeopardy and must be removed before they are aspirated. At the same time, you must protect the patient's spine due to the mechanism of injury. Therefore, you should manually stabilize the patient's head, log roll him onto his side, which allows drainage of blood from his mouth, and suction his mouth for up to 15 seconds. After ensuring that his airway is clear, assess his breathing and give high-flow oxygen or assist his ventilations. Nasal airways should not be used in patients with severe facial or head trauma. This is also very important as far as working together as a team. Remember, the person at the head is the one in charge and calls the shots. And you must also make sure that everyone in the team is properly placed so that you can successfully log roll this patient with as little movement to the spine as possible, or just no movement to the spine if you've practiced it well enough and are really sharp with it. So this is a skill that has to be practiced, and rotate practicing who's at the head and who's in charge, because it's not as easy as it sounds. It's actually a pretty difficult maneuver and requires a great deal of teamwork and communication. Let's look at the incorrect answers. To review the question or scenario, your patient is a 21-year-old male who has massive face and head trauma after being assaulted. He is lying supine, is semi-conscious, and has blood in his mouth. You should A, insert a nasal airway, assess his respirations, and give 100% oxygen. This is completely wrong because nasal airways should not be used in patients with severe facial or head trauma or with suspected fractures. You can end up jamming pieces of bone into the brain or actually getting the airway penetrating into the brain. So definitely do not do this. B, suction his airway and apply high flow oxygen via a non-rebreathing mask. Yes, you should do this, but this has to be done after manual stabilization of the spine and rolling the patient to his side. C, manually stabilize his head, log roll him onto his side, and suction his mouth. That's the correct answer. D, apply cervical collar, suction his airway, and begin assisting his ventilations. This is incorrect, and the rationale behind why this is incorrect is because the cervical collar should be applied, but manual stabilization must take place first. There are no indications here that the patient's rate of respirations are inadequate and require assisted ventilations. If that was the case, it would have been included in your scenario. Just a tip for test taking. Number 9, a man is found slumped over the steering wheel, unconscious, and making snoring sounds after an automobile accident. His head is turned to the side and his neck is flexed. You should A, gently rotate his head to correct the deformity. B, carefully hyperextend his neck to open his airway. C, apply an extrication collar with his head in the position found. Or D, manually stabilize his head and move it to a neutral inline position. We've had a lot of discussion about moving heads with suspected neck and head injuries. So let's see what the correct answer is. It is D. The patient's snoring sounds indicate an airway problem, which must be corrected or he may die. Manually stabilize his head, carefully move it to a neutral inline position, and then reassess his breathing. Do not rotate or hyperextend the neck of a patient with a possible spinal injury. The results could be disastrous. You just want to move the head just enough so that the snoring respirations cease and you have normal, clear air movement in and out of the lungs. Okay, it is all about minimalism when you're dealing with these types of injuries. Number 9, a man is found slumped over the steering wheel, unconscious, and making snoring sounds after an automobile accident. His head is turned to the side and his neck is flexed. You should. So let's review these incorrect answers. A, gently rotate his head to correct the deformity. This is not correct because you do not want to hyperextend the neck of a patient with a possible spinal injury. B, carefully hyperextend his neck to open his airway. Again, you don't want to hyperextend the neck of a patient with a possible spinal injury. C, apply an extrication collar with his head in the position found. The head must be placed in a neutral position to open the airway. And depending on how the neck is found, if it's turned like that, it's going to be extremely difficult to put an extra cervical collar or an extrication collar on them. So the correct answer is D. Manually stabilize his head and move it to a neutral inline position, gently and just enough to cease the snoring respirations and allow normal air flow in and out of the airway. You should not remove an injured football player's helmet if A cervical spine injury is suspected, even if the helmet fits loosely. B, the patient has a patent airway, even if he has breathing difficulty. C, he has broken teeth, but only if the helmet does not fit snugly in place. Or D, the face guard can easily be removed and there is no airway compromise. You should be able to get this one without too much effort. The answer is D. In general, you should always leave a helmet on if it fits snugly and does not allow movement of the head within the helmet, and as long as the patient's airway is patent and no airway problems are anticipated and the patient is breathing without difficulty. If you can easily remove the face guard, which is most often the case with football helmets, and there are no airway problems, do so, but leave the helmet on. If the helmet is loose, the airway is in any way compromised, or the patient has difficulty breathing, or is in cardiac arrest, then the helmet must be removed. And we covered a lot of different techniques for helmet removal, and there are a lot of skill sets in the chapter to remove. So this is definitely a skill set that needs to be practiced, and practiced as a team, and studied carefully. Let's check the incorrect answers. You should not remove an injured football player's helmet if A, a cervical spine injury is suspected, even if the helmet fits loosely. You should not remove the helmet because unless the helmet allows for movement of the head. If it's allowing for movement of the head, then it should be removed. But again, carefully and following proper technique. B, you should not remove an injured football player's helmet if the patient has a patent airway, even if he has breathing difficulty. The helmet has to be removed if the patient is having breathing difficulty, because you've got to be able to get equipment in, such as non-rebreather masks, for example. Perhaps they need suctioning, etc. You need to be able to have the helmet removed so that you can work properly on the patient. C, he has broken teeth, but only if the helmet does not fit snugly in place. Broken teeth present a potential for airway obstruction, so the helmet has to be removed, but again, with proper technique. And D, the face guard can easily be removed and there's no airway compromise. In this particular scenario, that's the correct answer. Class, thank you for your attention in this particular area of subject matter. Head and neck injuries and spinal injuries are difficult. They're difficult to manage, and there's a lot of complexity involved. So please make sure you study your terminology. Make sure that you get some study partners together and practice the skill drills, and be well acquainted with MOIs and their possible outcomes as they relate to head and neck injuries and spinal injuries. Again, thank you for your time and attention, and I will visit you next lecture.